First of all, I'm thankful to Nagpur OBGY Society and my dear friend Ashish for getting me here for this. This is not for the first time, this is almost fourth visit to Nagpur and second conference for me as a operating faculty. Thank you very much. I hope it shouldn't be an overdose of laparoscopy, because since in the morning we had a half-day workshop of laparoscopy and now again laparoscopy at the flag end of the day. So I'll be very quick. As Madam was saying about laparoscopy in cases where you are suspecting malignancy, but somehow in this vast topic I changed my approach and I have made it like few selected very common cases where the take-home messages or where the experience what it says and the guidelines or other people what they say. Just trying to mention about those practical points the way it was in our morning sessions. So let's start with that. Just keep in mind that yes, it is not very uncommon. The surgery for ovarian mass, yes, it is quite common. There is a good amount of chance of malignancy in those masses, and there is almost 10% chance that these ovarian masses, whatever we are suspecting, may be actually non-ovarian. Just I'll skip the list over here. Important points, these are actually take-home messages, but I thought I should put it in the beginning also, so the whole of the presentation can be seen from that perspective also. The management depends on age a lot. There is always a risk of malignancy in all the adnexal masses. Just keep in mind, unless until you go in the abdominal cavity and we get the final histopathology report, we need to keep our fingers crossed. There is a risk of recurrence which should be kept in mind, and all the management should be as per that. And it affects whatever surgery you are doing in the adnexa. It is going to affect the fertility, and of course it is a teamwork, especially from the radiologist and pathologist help which is needed. Without that we are incomplete. If it would have been an individual factor while managing a case, it would have been very simple, but we need to consider all these factors together, and then only we can have a particular approach towards a particular condition. We should have a proper history and clinical examination, but especially regarding endometriosis, where the disease may be quite widespread, but the symptoms may be very few. So it should be, the treatment should be very much symptom oriented. So a thorough history about dysmenorrhea, dyspareunia, dyschezia, dysuria, all these points should be taken into consideration, and along with the fertility, then only we should proceed. Familial ovarian cancers and acute ovarian accidents will guide us further. I'll skip all these things, and then how to assess the risk of malignancy. There are n number of criteria for it, but the most important criteria is your experience with those particular radiologists. At being in a small town, Sangli, we have only 6 or 7 radiologists, but out of that we are confined only with 2 radiologists, so that their tuning or their findings matches with our intro findings. And that is how I was saying about team with radiologists and pathologists. So this is a case of twisted ovarian cyst, very common. In a month, at least 2 cases we operate. This was a very young girl. She was almost around a 17-year-old, and she presented to a surgeon. A call was there from a surgeon that will you come for pain in abdomen, and ultrasound is showing a mass. So it was a freelancing surgery, and when we went there inside, we could see this is the ovary, look of the ovary. We thought of initially looking at the gangrenous ovary, we thought of initially removing it, but later on when we saw on the other side of the uterus, there was no adnex at all. There was no ovary, no tube on the other side. You can see here now. We haven't focused on it much, so we decided to conserve this ovary with whatever consequences we are going to have, especially from degeneration and infection point of view. Luckily, this lady, this girl, they called after around 2 months period and they said that she has got menstruation. So that means that it has started functioning again. So whatever bad look of the ovary you see, still think seriously about preserving that ovary, especially in such cases where the other ovary or the ovarian reserve on the other side you feel it is less. One of the other points in such cases is plication of the or fixation of the, sorry for the bad quality of the video, the other ovary. At the end of the procedure, what should we do? It is always fixation of the ovary is needed, it is must. Why it is must? Because we need to avoid the recurrence of the torsion, and that is why. So if you see it here, there are good number of techniques, and one of that it will mention with a very fascinating name, hot dog in bud technique, in which you go and through the mesosalpinx, through the ovarian ligament and through the round ligament and fix it. But all these things, they affect the tubo-ovarian relationship to a large extent, and the suture material which is used, that also carries a lot of significance. It should be as inert and as monofilament and long standing as possible, because when it gets dissolved, the suture material, it's going to affect, it's going to recur. The twist again is going to happen again. Here you have seen that we have plicated the infundibulopelvic ligament, and on the medial side we are plicating the utero-ovarian ligament also. So the key take-home message about this is, try to maintain the tubo-ovarian relationship when you are fixing the ovary, and try to use non-absorbable or delayed absorbable suture material which is monofilament, most inert. Tubo-ovarian abscesses, not so uncommon even in this era, and yes, this was one of the cases early, quite so many years back. This lady particularly presented with a lump in abdomen. She was a very thin built lady, so the lump was very palpable. She didn't have any history of pain or fever or anything. Only significant history was 6 months back she had undergone obstetric hysterectomy for postpartum hemorrhage in twin gestation. It was cesarean section, and she had undergone obstetric hysterectomy at that time. So when we saw this, we dissected it out and it was removed through colpotomy, and we thought the bowel is intact. But on third post-operative day, she developed signs and symptoms of peritonitis, fecal peritonitis to be precise, with the drain, and we had to do resection anastomosis at that particular time. Adoscopy was done, bowel was checked over here, where it was only inspection for any telltale signs of injury or giving way, but we didn't see, that's why we just left it. Similar kind of case over here. She was young girl with maybe something around 24-25 years of age. You can see here the whole of the thing, it has become one single mass, and that is the bowel which is densely adherent over there. Actually it has become part of the fallopian tube and ovary on right side. On the left side there was an endometrioma. She hadn't undergone any procedure beforehand. This was an endometrioma on the left side, and when we started dissecting on the right side, it was very meticulous dissection. It took almost 3.5 to 4 hours for us to finish with this, and at the end when we tried to check, inspection only again with the bowel, and as it was small bowel, with that we didn't find much any of the troubles intraoperative. On 5th day when we started her with liquids, she was stable till 5th day. On 5th day when she was started with liquids, she gave away, and it was the drain which was kept inside that started draining bilious material. So we opened her up and did resection anastomosis for her. So the take home message from these two cases is, when you see that the wall of the bowel is so much adherent, densely adherent throughout to the abscess, then keep in a mind about diversion. So diversion stoma, that will be helpful in such cases, so as to avoid the further laparotomy, and definitely it will be inconvenience for those 3-4 months, but it will save a lot. And you can see the dense adhesions over here. So with these two, it's not like for each and every tubo-ovarian abscess and bowel adhesions we need to do a stoma, but especially when you see such dense adhesions, then you should think about diversion stoma in these cases. Okay. Ectopic pregnancy, we know all of us very well the management of various sites, various locations of ectopic pregnancy and the management, ruptured, unruptured, cornual, all those things. But there is one entity which always mimics like an adnexal mass. It is silent ectopic, it is chronic ectopic, and the only way to diagnose that is with histopathology. This was one of the lady in her early 40s where we had planned hysterectomy for her for ovarian cyst or adnexal mass and abnormal uterine bleeding. So after adhesive, what we found was there was endometrioma on the right side, and on the left side there was another mass which was densely adherent. After adhesive, and you can see the mass over here, the white one, which is densely adherent with the uterus posterior surface. After adhesive, when we got the histopathology, it was a chronic ectopic pregnancy. Beta HCG levels were very less, not significant one, but the tissue was suggestive of chronic ectopic, and this should be kept in mind sometimes. A very rare finding till date, not more than 4 or 5 cases of chronic ectopic for us. There was one interesting case of uterine rupture, that was acute intra-Pattern, subacute intra-Pattern uterine rupture, which was detected on 4th post-operative day, which was confirmed with ultrasound and MRI. Unfortunately, I didn't get time to add that video. Twisted ovarian cyst we have seen, but sometimes there is a twist to this twisted adnexa. So this particular lady, when we saw that ovary was fine, absolutely fine, but still she was having persistent pain, and because of that we thought of going ahead with diagnostic scopy, and this mass was there, ovarian cyst, a cystic mass was there in the adnexa. So that's why we went ahead with the procedure, scopy, and to proceed further depending on the intraoperative findings. These are the fimbria which you can see, little changes of ischemia in it. The ampullary portion still looks pinkish, so the other tube and ovary is fine completely. So when we saw it carefully, ovary on the left side you can see it very well. This is a third case of isolated tubal twist. This is and second one, I don't remember what exactly it was, but this lady and the other lady who was para 2 leaving 2, in both these cases there was a para-ovarian cyst, and because of that para-ovarian cyst, she had isolated tubal twist. So that is why the dictum for para-ovarian cyst, even if it is small one, we should go and remove it, because the risk of tubal torsion is quite significant. That's the reason why all the para-ovarian cysts need to be removed. What we did for her, it was cystectomy for her and then plication of the infundibulopelvic ligament for her because it was quite lengthened. We have already seen plication of the infundibulopelvic, so I won't go for that. On most of the occasions with twisted ovarian cyst, we hardly get anything cystic content inside. So if it is not there, it's more of a hemorrhage and edema, and because of that, you just untwist it and fix the ovary, and it will take care of her symptoms further. This was one very interesting lady. She came to us with dyspareunia and very atypical symptom of discharge per vagina after coital activity. That discharge used to stay there for almost 10 to 15 days, and with this very specific history, she was very thinly built lady. It was abdominal hysterectomy which she had undergone earlier. On speculum examination, there was query fimbria, query granulation tissue at the vault, but the significant finding was clinical examination. What was that clinical examination? As I said earlier, the clinical examination and history points to a lot. Over here, she being very thin built, when I did bimanual examination, both the ovaries, they were palpable at the vault. So that's gave me some idea. This might be the reason for her dyspareunia. And then when we went inside, the findings were confirmed. Both the ovaries, they were adherent at the vault, and there was something else, that was the fimbrial prolapse through a gap over there. And that fimbrial prolapse, because of which she was having direct continuity of the pelvic cavity and peritoneal cavity to the vagina. So with each coital activity, there used to be infection, and that used to give rise to her prolonged, that is opening of the vault, you can see, and that was the fimbrial prolapse through that, and that was the reason for her prolonged discharge and pain along with this. So that was the fimbria which is prolapsing. You can make it out very clearly. What we did for her, we did adhesive lysis, we released both the ovaries, and this tube, both the fallopian tubes, they were removed, and ovaries were transfixed higher up away from the vault, and vault was repaired. So that is how. Okay. Recently had a case of dysmenorrhea. Why the videos are like this, I do not understand. It was looking quite well when I prepared them, but this particular lady, it was a very young girl. She presented with dysmenorrhea just with immediately after her menarche, and that was both the functional horns of the uterus, diadelphys, and one was communicating and the other was non-communicating, and because of that she had these dysmenorrhea, very severe one. Dissected the ureter out, something wrong. Okay, so dissected the ureter on before going ahead with further dissection. That was the adhesive lysis because of the endometriosis on left side. It was hematometra and hematosalpinx. After careful dissection, this left horn was released completely from all sides. We can make out the typical of diadelphys uterus, the peritoneal fold along with the fat inside between the two horns of the uterus. So after this, we did excision of the left functional horn. That was what I was talking about. This is that peritoneal fold. We excised it. Why I want to highlight this particular case before the next case is because next case she also presented within a 3 to 4 months period after her menarche with dysmenorrhea, and over here they said that it was hematometra, there was collection inside, and hematosalpinx. MRI was so pinpoint that they even mentioned this endometriotic nodule. So it wasn't much because she had hardly 3 or 4 cycles, and because of that there is not much of endometriosis in the peritoneal cavity. So compared to the previous case, what you can make out over here is the morphology of the uterus, which is much more like one single uterus and an oblique intrauterine septum which is obstructing the left side of the cavity. So unfortunately she had hydrosalpinx on the functional side. So what we did was, we initially tried to resect that septum, the oblique intrauterine septum, through the hysteroscope, but as the anatomy was not very clear, we thought of some different approach, and we opened the cavity from above through the laparoscope so that we will have some guide for us, and this vasopressin injection needle, that is VVI needle, was a guide for us. We put that needle in the uterine cavity and then we resected that septum, intrauterine oblique septum. You can see the needle here, this is the needle, and then we resected it. After resection, to avoid restenosis or avoid formation of adhesions, we kept the number 8 Foley's catheter inside, and that is the Foley's catheter, and we sutured this defect on top of it. This was done recently, not even just 2 weeks now. What we have planned for her is relook hysteroscopy after around 2 cycles. She is on estrogen now. This particular girl, very young girl, hardly 20 years old, and she presented with ascites. She presented to us with bilateral ovarian masses. Then why did we do laparoscopy for her? Because all her investigations to rule out malignancy as well as to rule out tuberculosis, they were negative. So there was no malignant cells on the ascitic tract. We didn't do biopsy for her, but this was the intraoperative finding. And when we took, you can see the the peritoneal deposits also, along with omental deposits. All these things were the omental deposits and ascites and bilateral masses. This was picked up on ultrasound as well as MRI, and this biopsy was suggestive of high-grade adenocarcinoma, the primary of which we still don't know because this was just 1 week back. We are waiting for the final histopathology report for the primary origin of this. So instead of going ahead with anything else, just one point about hemostasis after ovarian cystectomy. Do nothing means give some time for that bleeding to stop on its own. It stops on majority of the times. We can use vasopressin very effectively and it works wonderfully. Bipolar coagulation, strict no for that. When you compare stitch with absorbable suture and bipolar coagulation, stitch does better in terms of preserving the fertility, which was calculated with AMH. Few people have used epinephrine also as effective as vasopressin. Laser plasma jet and hemostatic agents, they give us hemostasis with much lesser of damage to the fertility on the that side of the ovary. Reconstructing the ovary with large cystectomy with irregular tears, we try to reconstruct the ovary, but we strictly avoid doing that. Why? Because there are various layers of the ovary, and when we are trying to reconstruct, we are trying to change that anatomy, and each layer, the surface, it needs to be on the external side only. Otherwise, the ovulation will not happen, and that is the reason why we give chance for that ovary to heal on its own and to reshape on its own rather than reconstructing it. So once again, the The treatment should be dependent on age. There is always a risk of malignancy which should be thought well. We should keep the things ready for that. Counsel the patient related with that. Counsel the patient about the risk of recurrence. So we need to balance both these risks along with the effect of the surgery or treatment on the fertility, and it's always a teamwork. So thank you very much.